All right, good morning again, everyone. So this is our first major plenary for the meeting. And as we're getting started, I do want to start with just a quick thank you, first of all, to all of you for coming and for showing up as we did yesterday. I also do want to thank our corporate sponsors who are supporting the meeting with us today and are joining us for today, tomorrow. Very much appreciate your contributions and your work with NASTAD. As many of you know, and we talked about this yesterday during our various conversations, we are really committed both as a membership and as an organization to syndemic approaches to implementing and achieving our mission and vision of ending the HIV epidemic and hepatitis epidemics and all, drug use, overdose epidemic, et cetera. And so this panel, as you will notice, we tried to reflect that. Obviously, there are other members of or other contributions to a syndemic approach that would lend itself to being part of this panel, i.e. housing or other social determinants of health, but we probably would be having this session until 12 o'clock this afternoon. So what we've done is we've invited our colleagues at ONAP, colleagues from other offices within the White House, i.e. the Mpox coordination office, our colleagues from CDC's division of prevention, division of viral hepatitis, the STI division, and our colleagues from HRSA to give us an update on their contributions or the federal partners' contributions to our theme for this year's meeting, which is focusing and recentering key populations. So with that, I had a chance to look at the various slides from our colleagues, and there's a lot of really good information. So I'm going to shut up and give these guys an opportunity to do the presentation. And so let me just run down the order. We've got Mr. Harold Phillips, who is the director of the White House Office of National AIDS Policy, followed by Dr. Daskalakis, who is the Deputy Coordinator of the White House National Mpox Response, Dr. Neblit Fanfare, who is the Acting Division Director and Principal Deputy Director of CDC's Division of HIV Prevention, will go after Dr. Daskalakis. Dr. Gupta, the Chief of Epidemiology and Surveillance Branch at CDC's Division of Viral Hepatitis. Dr. Ballard, Diane Ballard, who is a public health analyst in the Division of STD Prevention at CDC, and then Dr. Cheever, who's the Associate Administrator of the HIV/AIDS Bureau. So with that, I will hand it over to you, Harold.
Thank you, Stephen. Good morning, everyone. So, Stephen, I got a little scared there. I looked at the number of slides, but that's the combined number of slides. I'm not talking that long. You will be here all day. Good morning. I am so happy to be here with you. It's always great to be at the NASTAD meeting and reconnect with many of you all as well. So I'm going to talk a little bit about the president's budget and how it connects to recentering key populations. Did that move? Do I need to do something? It did move?
Actually, you need to do this. Sorry.
Oh, I need to do this thing.
You're going to have to
I have to. Oh, let's do both. Okay, got it. All right. So I'm going to talk about the president's budget and how it connects to our theme this morning of centering on key populations. In the 2024 budget proposal, the president has done a couple of things. One, sort of show a continued commitment to the Ending the HIV Epidemic Initiative and continuing the request for $850 million, which would be a $277 million increase over FY 2023 enacted. The funding would still go to the agencies that you see here, the agencies and programs that we see here on the screen. I know that many of my colleagues will talk about some of the work that has been done in EHE and some of the tremendous success. And also, this is a great opportunity to also thank you all for the work that you've done moving EHE forward during tremendous times of both COVID-19 and Mpox. The president also calls for a national PrEP program to advance equitable access to PrEP by providing PrEP at no cost, limiting costs for enabling services, and establishing a provider network in underserved communities. In that funding proposal, it talks about $237 million for the first year. Talks about this have moved a bit farther than they did last year. In that OMB is working with HHS and also with legislative affairs to really, I think, turn this into a legislative proposal. Part of that legislative proposal includes several components that involve both the Ryan White program as well as CDC in reaching and closing our PrEP gap when it comes to those who are uninsured and underinsured. This program would sit on top of other existing programs, so it doesn't take away from the work that is already underway to scale up PrEP access as well. The budget also calls for states' Medicaid and CHIP beneficiaries to cover PrEP and associated lab costs with no cost sharing as well. So you can see how both of those together are moving us in a direction where we're increasing access to PrEP and especially targeting our key populations. Also, the hepatitis C elimination program is continuing to move forward as well. And they too are moving toward that, turning the proposal into legislation as well. I forgot to also say the PrEP program is on the mandatory side of the budget, which, you know, there's been some debate about mandatory versus discretionary, but it's there. And I think one of the messages is that by the president putting it in the budget as a mandatory proposal, he is saying that those who are at risk for HIV and uninsured and underinsured are entitled to access to HIV prevention medications. So that's a pretty strong statement as you sort of think about what's the difference between a mandatory and a discretionary program. Also increases in some of our very key programs that reach those who are at risk and living with HIV as well. And also steps to hopefully this year modernize the state eligibility for the HIV set aside for a SAMHSA's grant using HIV cases instead of AIDS cases. There was some work on that last year and it didn't get across the line, but we're hoping again this year it does, and it would make a difference because I think last year there were 3 or 4 states that would be eligible. This would bump it up to, I've heard numbers from 12 to 20, but much more. And so really putting additional resources at our disposal to be able to address the HIV epidemic. So I'm going to talk about NHOS and the EHE initiative and give just a few updates. So we recently convened a meeting, thank you to HUD and CDC, and HRSA was also in the room, and the meeting focused on sort of addressing the housing challenges. We all know that housing is a major determinant of health, but really and truly, we spent the day thinking, learning from programs that are innovative and doing the work, and really thinking about sort of what's getting in the way. Very often it's some of our federal policies, procedures, categorical funding, and how do we close that gap? So there was a lot of discussion around those pieces and thinking through sort of what the follow-up will be. Indian Health Services is expanding its training for PEP-related services, and we're continuing to focus on rapid start and linkage to care. Just Friday, or last week, I was in New Orleans and heard a lot about sort of how they're moving their programs forward when it comes to rapid start and linkage to care, and really thinking about what are the models that are really working. And there seems to be some variation as well. Was recently also in a meeting with several jurisdictions who are implementing rapid start and targeting key populations such as the homeless, and also learning more about some of the challenges with rapid start as well, and rapid start versus re-engagement. So We are also continuing our work on HIV criminalization laws and regulations as well, and its connection, or how some have connected it to molecular HIV surveillance. And I'll probably talk a little bit about that as well. So we are also trying to do a better job at telling the story of EHE. Sort of what have we done and what have we accomplished, and where have we not accomplished what we thought we would accomplish, and those challenges. I know that many of you were faced with challenges in trying to spend the EHE money that you received, and the EHE money, and the COVID money, and COVID itself, and then Mpox came along, and all the rest of that. Understand that, but we need to also do a better job of telling that story, but I also need you to catch up, because it's really hard here in Washington to advocate for additional funds when there's a lot of money left on the table. So as the stories are coming out, and we need more of them, we want to be able to tell that story, but we also need you to catch up. And we're also looking towards the future of the initiative and some of the lessons learned from the first several years. So what have we been up to as an administration? Well, since January 2023, there's been a lot going on. There's the clinical guidelines update for infant feeding to support a variety of feeding options. This also, lots of great work from the committee that really looked at this. And this is really a great example of listening to the community and the community concerns. I think when I first took this job and heard about the challenges of women who were threatened by Child Protective Services, they were HIV positive, they were undetectable, in treatment, and yet many providers would not talk to them about their child feeding options, and the fear and the isolation that those women had. So I'm really happy and glad that we were, and actually proud that we were able to get these out and get these refined in a way that I think meets community needs, but also still protects the American public and their children. The FDA blood donation recommendation on using a risk-based questionnaire. And so this was a long struggle, and also a commitment that the administration made that we were going to get this done. And this happened a few weeks ago. And so that's also very exciting news. CMS moving forward with its national coverage analysis for Medicare and coverage of PrEP, which will inform the national coverage determination. We expect that decision to also be coming out later this year as well. So things are also moving forward. DOD rolled out additional information on PrEP, so they are also sort of on board and continuing to move forward. And DOJ's data report on people with HIV in state and federal correctional facilities. We'll continue you'll hear a lot more about this from the federal partners, the focus on the syndemic of STIs, but also substance use disorder and hepatitis C. We continue to collaborate with our partners in the White House on the National Drug Control Policy and looking at ways to address stimulant meth use, and their ongoing conversations about criminalization as well. We have also lost our private-public sector partnership as of World AIDS Day, and activities have continued to move forward. There was the National Employer Summit that was also recently. Many of the companies that are involved are reviewing their own internal policies and guidelines and updating them. We formed a leadership council. That leadership council is meeting and coming up with some policy recommendations regarding pharmacists and PEP and PrEP. So we're excited about that in ways that we can look at not only expanding the scope of practice, but also thinking about some of the payment issues that are getting in the way, which several of you are probably well aware. We're also looking at ways, like I said earlier, we had the roundtable a couple of weeks ago to look at the housing challenges and think, did I go backwards? And things that we could do differently. We're continuing to work with our colleagues across the federal spectrum to that's what happens when you have one cup of coffee. Spectrum, not the specter, but the spectrum. To implement to work toward implementation science and really work on ensuring that we're using our best practices and that we are infusing all of our efforts, our funding opportunities, and also technical assistance around some of those best practices. I talked about the Pharmacy Association work that we're doing in scope of practice. We had recent success in Arkansas as well, which that was really exciting. We're also thinking about the role of technology. We have both workforce issues, but we also have workflow issues, and really thinking about how AI and technology can really help address some of that as well. Addressing challenges. National PrEP program, getting this over the hump is going to be a huge lift, and we are really looking at that. Really looking at the STI rates and thinking about sort of that intersection and the way the STI crisis intersects with our work to end the HIV epidemic. We've got to do this in consort. Also, thinking about status neutral, no wrong door, ways to blend and braid funding streams across the spectrum. The other thing that I will say is that and I need to wrap up, is that EHE and its 4 pillars are still moving forward. This also means the pillar when it comes to molecular surveillance. So I'm sure I'll get lots of questions on that, but just wanted to throw that little nugget in there for you to think about. We need you all to continue to move forward. Thank you.
Hi, everyone. I'm Demetre Daskalakis, Deputy Mpox Coordinator. And today I'm just going to give you a quick tour of Mpox, making sure that we are on the same page with the most recent information, and then also make sure that if you have questions, I am available here. So just quickly, some state of the epidemiology where we are today. So as of May 17th, the epidemiology was updated. We're just over 30,400 cases in the United States with 42 deaths. We are going to focus in on those deaths in a second because it really is about syndemic and the importance of weaving together multiple infectious and non-infectious disease strategies to address these outbreaks. The map shows you the darker the state or jurisdiction, the larger the number of cases in that jurisdiction. This is what the epi curve looks like in the United States. Trends continue to be on target, on average between 0 and 2 cases per day in the US. It is important to remember that there is a cluster happening in Chicago, which I'll talk about in a second, but the national trends remain the same, although we are closely observing across jurisdictions with more information coming if there are new clusters or new scenarios happening other than Chicago. I'm about to shout out Dave Kern in a moment, but we're not quite there yet, Dave. So in terms of what we're seeing, in terms of the outbreak, continuously seeing the same trends in race and ethnicity. About 60% of the cases in the United States are occurring in Black and Latino individuals. The majority cisgender men, although about 3% are women, 0.8% are transgender women, 0.2% trans men, and the rest are folks with other gender identities. And really the ages really focus around the 20s to 50 range, with the peak being in that 31 to 35 range. So those trends are pretty stable given the fact that we're accruing not a lot of cases per day. This is my shout out to Dave Kern, who's in the back. Hi, Dave. So really great sort of example of communication between local jurisdictions, the White House, as well as CDC and other components of the response, really making sure that as we heard about a evolving situation, things moved really quickly. And this is an excellent health alert that Chicago released. And I'll say that right now we have a team on the ground working closely with Chicago to learn more about the situation of the cases. If you haven't heard, and I'm going to look at Dave, my numbers may be wrong now, 26 is about the count that we've heard, 57% fully vaccinated, and the rest some combination of partially and incomplete vaccination. The big message here is that vaccine works even when you think it doesn't, because the people who are getting the infection tend to have pretty mild disease. So the vaccine mission continues. And so this is where I noticed my typo. Everyone, I can spell prevention. but not last night. So I just want to focus a little bit about on what we're doing with Mpox prevention and just remind you of what that full toolkit looks like. And speaking of syndemics, we start with the sexual health toolkit. And inside that toolkit is our Mpox prevention toolkit that we all have learned to use. First part, vaccine prevents infections and complications of Mpox. We're seeing that in real time, even with cases that are happening that have been vaccinated. Testing, really critical, identifies infections and does two things: allows for public health action, as well as leading people to the STOMP trial, where they're able to access TPOXX, and also so we can learn if TPOXX works. And then finally, education, really informing people about how Mpox is transmitted and their local scenario, so that they can make informed decisions about their own sex life, regardless of their vaccine status. It is a syndemic after all, and overlapping that are resources in mental health as well as housing that can be leveraged to support people who are affected by Mpox. So this is my summary slide of all of the amazing things that happened on May 18th. So as we were learning about Chicago, we also learned a lot about how the vaccine performs through three studies that were released simultaneously on the 18th. The first was a multi-jurisdictional view into how vaccine is working. And a couple of the important takeaways is there was no difference between subcutaneous or intradermal administration of vaccine. And at least looking at the immunocompromised folks in that study, which again, they were not profoundly immunocompromised, it was self-report. There does not seem to be a difference in vaccine effectiveness across those communities. So the first and second dose vaccine effectiveness, 75 and 86% respectively. The second study was in the New England Journal of Medicine. This is an EMR-based study with a huge N. It was a little less selective about like the risk level of the individuals in the study. And what it found was what we kind of had been reporting before: 35% for a single dose and 66% vaccine effectiveness for a full second dose. And then finally, New York State in the House, hi New York State, has their own study that came out. And in this one, they actually looked at individuals. The cases were Mpox and the controls were folks who had an incident rectal STI or primary syphilis. And so what they found is also a very high level vaccine effectiveness. Important message, and this is where it gets a little like an M.P.H class, the confidence intervals overlap, so they're all about the same. I always tend to tell people to assume the worst. So live your life as though it's 66%, not that it's 90. And that tends to be good guidance in terms of how to approach it. But the take home is 0 doses, 0 VE. So the fact that we are seeing a pretty effective vaccine and getting people fully vaccinated continues to be our mission to be able to complete the job. And this is the job that we haven't completed. 1.2 million doses administered in the United States. That curve trails down at the end, just like the cases, out of sight, out of mind. So despite all the work that you all have done and all the work to sort of put vaccine in the world, we really have a job to convince folks that we need to sort of increase awareness and really complete the vaccination mission in the US. Also important to remember that there is a very significant equity overlap here in terms of what we're seeing when you compare vaccine administration to cases. CDC did this amazing analysis, which should look very familiar to you if you follow the PrEP to need ratio, where they asked the question, how many people are being vaccinated compared to cases? So for every one white person who was vaccinated, who was a case, 43 were vaccinated. For every one Latinx person who was a case, 17 were vaccinated. And for every Black person who was a case, 9 people were vaccinated. And that's the graph that's generated. So when that one passed in front of my desk, I said, wow, that's really familiar, because it looks like the PrEP to need ratio that's published by AIDS View. It's very similar and really demonstrates that the fault line of systemic racism continues to hinder our ability to implement biological as well as behavioral interventions to prevent infections, Mpox and HIV included. CDC has released amazing models that we actually started talking about in March that says that we are not out of the woods. They asked the question, how high do you need to go for vaccine to be able to prevent outbreaks? And is there a threshold above which we're protected from larger outbreaks? The answer is the higher you go, the better you do. So it's an inverse linear relationship. So high immunity means low risk for an outbreak. And if you vaccinate more than 35 to 30% of people, your risk of having a larger outbreak goes down. So we have our mission. We need to do more vaccinating. On the 18th, CDC released a brand new risk assessment, on the 17th of May. And that risk assessment says that we are at substantial risk for ongoing outbreaks. So again, the reminder of the initial model, ongoing work to increase vaccination continues to be our core strategy. In terms of Mpox therapeutics, I think you all remember the bad old days of it's really hard to get TPOX. Well, a lot of work happened across US government to make sure that that was made a lot easier. We have another component of the mission that as we see cases, we really need to focus on, and that's recruiting the STOMP trial. So about 7,000 courses of TPOX have been administered in the US through the CDC EAIND. That's wonderful. It proves that the drug is accessible and that it's safe. We have no idea if it works. It is an investigational drug. So we're really trying to stilt the odds in our favor with a process that will eventually move us first to get people evaluated for STOMP. They've made it really easy with remote access. That even means in rural locations, and then home delivery of the drug. So we're really encouraging folks to use the STOMP mechanism to get access to drug, which will also include the ability to go in through the EAIND. And this is where I get to talk about the Mpox syndemic, which is one of our themes here. And just to remind you that this is a rare moment where we actually see a new infection entering a syndemic. We saw it in real time. So Mpox interacts with HIV and STI. They live in the same populations, they're in the same zip code, and there may be something biological about them. But then when you add the social determinants of health on top of them, racism, homophobia, transphobia, and housing, all of a sudden you make that a much more significant and denser meteorite that hits our community in a way stronger way, resulting in severe outcomes. Here's the story. So 38% of people living with Mpox or diagnosed with Mpox were also diagnosed with HIV. That's the first time that we really saw that they were living in the same zip code. And then what we saw was that the cases were worse in people living with HIV, especially if their HIV was not as well controlled, as marked by hospitalization. 1 month later, CDC released information about people hospitalized, the most severe cases of Mpox in the country. 82% of them had HIV, 74% had a CD4 count, that's a CD4 count, not a viral load, of less than 50. Almost none of them were on medicines, and as predicted, the syndemic did its syndemic thing, it's syndemic, as it were, and systemic racism and homelessness came together to make the impact far worse. Flash forward to the deaths. Same story. The majority, 87%, were Black. Most were cisgender men. Of the folks that had HIV data, their T cell counts were less than 50. So additionally, other studies that were done that demonstrated that in homeless populations who were diagnosed with Mpox, this is in LA County, 60% of them were living with HIV, only half were virally suppressed. We get the picture. So syndemic challenges require syndemic solutions. We were able to weave together resources from HRSA, CDC, HUD, SAMHSA to allow flexibilities so that the whole machine can be moved to address Mpox as needed. So please avail yourself of those. And I know this to wrap up, I'm gonna go so fast. We have some great summer resources for you. So in a syndemic strategy, we've released at CDC this great website. It covers travelers' health, STI, HIV, sexual health, Mpox, COVID, and drug user health all in one site. Please link to it. It has a lot of good information. We've also created an entire universe across US government of different materials that could be helpful in terms of Mpox work. And we have been going overdrive since February with engagements across the entire world, making sure that people knew that we are not out of the woods yet. And so thank you to Chicago for not for having cases, but thank you for Chicago for elevating this, because it's really helped us get more attention to be able to motivate the effort. So again, end of the day, we're approaching our communities with joy and love. HIV, STI knows how to do this, so continue to do it in that way. We need to vaccinate, 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 but use all the components in the toolkit, including testing and behavioral interventions, and really make sure that we keep a syndemic view in terms of how we're delivering our services, because that's how it seems people would like to get their care. Thank you.
It's taller than I am. Good morning, everyone. It's a pleasure to be here. I'm here representing the Division of HIV Prevention at CDC as the acting director, and I am joined by so many DHP leaders in this space. We look forward to engaging with you during the Q&A session as well as throughout the meeting. So first, I'd like to spend my time today talking with you about how DHP is approaching our work with key populations. In particular, we are using the cross-cutting focus areas in our recently updated strategic plan supplement. Our focus areas include health equity, community engagement, syndemic approaches, and holistic approaches. Before I go into what DHP is doing to engage key populations, I'd like to provide a brief overview of the data. Hold on. It's not moving for me. There we go. Oop. Well, it moved a little quicker. Let's first set the framework for why these disparities exist. Racism, systemic inequities, social and economic marginalization, residential segregation, and other long-standing barriers are among the key drivers of the disproportionate impact that HIV has on some communities, particularly Black and Hispanic, Latino, bisexual, and other men who have sex with men, women of transgender experience, and cisgender Black women. So given the interruptions in 2020 related to COVID-19, I will be presenting 2019 data today. Many of you have received an overview and a preview last week from our HIV surveillance branch, and our 2021 surveillance data will be officially released tomorrow. In 2019, of the total 36,801 new HIV diagnoses in the US, the majority were among gay, bisexual, and other men who have sex with men, who make up nearly 70% of new diagnoses. Geographic disparities exist as well, with over half of new HIV diagnoses among people living in the South. The fourth bar from the top shows the number of new diagnoses among Black women attributed to heterosexual contact, which is around 9% of new diagnoses. The data on this slide shows the number of new HIV diagnoses among women by race and ethnicity. And in 2019, Black women continued to be disproportionately impacted by HIV, accounting for 54% of new diagnoses among women. In 2019, the data for transgender women show that Black women of transgender experience accounted for 46% of the 625 new HIV diagnoses among transgender women. Hispanic Latino women accounted for 35% of new diagnoses among transgender women. Now let's take a look at where things stand in the Ending the HIV Epidemic, or EHE Prevent pillar. PrEP is underutilized, and we have extraordinary work to do to ensure that PrEP is equitably reaching people who could benefit, including Black, Hispanic, Latino communities, and women. Racial disparities in PrEP use are stark. Among those with indications for PrEP, only 9% of Black people and 16% of Hispanic Latino people are using PrEP versus 66% for white people. According to the 2021 National HIV Behavioral Surveillance data, 89% of gay, bisexual, and other men who have sex with men without HIV were aware of PrEP. However, only 42% used PrEP. And NHBS data show that while 92% of transgender women without HIV had heard of PrEP, only 32% had used PrEP in the last 12 months. People with HIV who take HIV medicine as prescribed and get and keep an undetectable viral load will not transmit HIV to their sexual partners and can live a long and healthy life. In 2019, nationally, 76% of persons diagnosed with HIV have received some care, but only 66% were virally suppressed. And for women and Black, gay, and bisexual men in particular, the viral suppression values are lower than the national values. So despite scientific, technologic, and biomedical developments, HIV prevention treatment services are still not reaching all who need them due to stigma, homophobia, discrimination, transphobia, and so many other structural factors. So let's talk a little bit about what DHP is doing to engage the community, to gain a better understanding of the challenges for key populations in accessing HIV prevention and care services. Community engagement is paramount to EHE and engaging key populations. EHE funding includes a focus on ongoing community engagement. DHP recognized that there was an opportunity to expand how we engage with people with lived experiences and community to increase the number and diversity of our partnerships. These principles served as the foundation for our community-centered engagement. So starting last year, we convened multiple HIV prevention and care priorities, regional virtual community engagement town halls, and leadership roundtables by HHS region. We were able to hear from all HHS regions and engage directly with over 1,200 community leaders and members to discuss community-driven solutions to advance HIV prevention, diagnosis, and treatment. Some of the high-level themes that have emerged include breaking down silos in funding and cross-collaborative work happening across federal agencies, expansion of HIV testing in emergency rooms, primary clinics, and pharmacies, increased focus on providing housing, employment opportunities, and mental health services, ensuring the EHE initiative considers the whole person versus only supporting a biomedical model, an increased focus on transgender and cisgender populations to include data collection to inform research and program. Now I take a moment to share some areas where DHP is working to address HIV prevention, treatment, and care needs for key populations. First, let's go pillar by pillar. So in 2021, we launched our first ever direct-to-consumer internet-based distribution program, Together Take Me Home, to provide 100,000 free HIV test kits to anyone who requested one. This program was very successful in reaching people of the global majority. Of the 100,000 free HIV self-test kits, 63% were among Black, Hispanic, Latino, Indigenous, and other people of color. 10% were among Black cisgender women, and 1.4% were among transgender women, of which 24% had never tested before. Due to this success, DHP funded Emory University and other partners to continue Together Take Me Home with a goal to distribute 1 million rapid HIV self-test kits over the course of the 5-year project. DHP collaborates with partners and providers so people who receive a positive HIV test result are quickly linked to care and receive treatment as soon as possible. We know that Black and Hispanic Latino communities are more likely to have delayed ART start after HIV diagnosis. Rapid ART ensures equal access to care for all persons living with HIV. DHP is also leveraging pharmacy data to improve retention and care, treatment adherence, and viral suppression. We're working with our partners to implement PrEP navigation that can increase knowledge, demand, access, and persistence. Even though there are existing programs that provide PrEP at low or no cost, patients often need help to navigate the requirements for these programs. So in one example, DeKalb County used EHE resources to train nurses to offer PrEP. 70% of clients served by this organization are Black, and many clients have low income or no health insurance to pay for PrEP medication. The clients at this health center receive customized, non-judgmental information about how to integrate PrEP into their daily lives. In 2021, our Let's Stop HIV Together campaign launched a new initiative called She's Well, which is focused on increasing awareness around PrEP among women, building capacity among clinicians to prescribe PrEP to women, and ultimately increasing PrEP use among women. The campaign approach for Black cisgender women is to implement with intentionality. We developed a webisode featuring Black women talking openly about HIV and other sexual health topics. Also, we have a variety of print materials and digital assets tailored and developed for, and I would say also by, Black women. DHP also addresses HIV prevention in key populations through our syndemic investments in syringe service programs. In 2021, approximately 108 SSPs were supported in EHE jurisdictions. 57 are fixed locations and 51 are mobile. The photos on this slide are from an SSP in New Jersey that operates out of both brick and mortar and mobile units. And finally, in the respond pillar, here's an example in which strong collaboration with community-based organizations, healthcare providers, and health departments has helped with a swift and community-centered response. In 2021, Michigan identified a molecular cluster of rapid transmission in Detroit, affecting a network that included Black women of transgender experience. The health department immediately began engaging with community partners that serve trans communities to talk through potential gaps in services. What they found was that there was a lack of providers providing gender-affirming care. So as a result, Michigan has created a mobile service initiative offering gender-affirming care that includes general health and wellness checks, immunizations, and a local food pantry, in addition to HIV and STI testing. We focus on key populations in our program, research, and capacity building. One example for program includes the Notice of Funding Opportunity PS 2203. Last year, CDC awarded funding to 36 community-based organizations to develop and implement HIV prevention program specifically for young men of color who have sex with men, young transgender persons of color, and their partners. Earlier this year, CDC announced 6 Notice of Funding Opportunities with a focus on improving health equity. All of them are listed here, but I'd like to highlight just a few. HRPrep is an implementation research project to evaluate strategies to increase PrEP use among Black cisgender women in the United States. And we're also working to identify and address historical and structural drivers of medical mistrust among Hispanic, Latino, gay, bisexual, and other men who have sex with men. And when we think of capacity building, CDC has a robust library of proven effective interventions. There are numerous interventions that are focused on key populations, some highlighted here, that focus on cis and transgender women, Black and Hispanic, Latino, gay, bisexual, and other men who have sex with men. We know that ongoing community engagement efforts are critical to access, engage, and activate our key populations. CDC is committed to continue to center key populations through meaningful, ongoing community engagement efforts at the national, state, and local level. Therefore, the division will continue to prioritize hearing directly from the community and partners, as well as provide partners with resources and tools. We are doing this by meeting directly with partners. This picture on the left is from a recent visit that we had right in our own backyard to Thrive SS. We are going to be partnering with our sister agency, HRSA, to start co-listening sessions that are going to start next month. And also we will be traveling hopefully to a town near you. We're planning a series of meetings with local leadership and staff from community-based organizations, and we're going to be starting by visiting CBOs in the South this summer. I think I made it in time. Thank you.
Well, good morning. So first of all, Dr. Wester, our director, sends her apologies that she couldn't be here this morning. She will be here later in the meeting, but it does mean I'm sorry you got me. Full disclosure, my head is in data most of the time, but I'll try my best to really represent the work of our division and our health department colleagues and our partners. So to do that, I'm going to provide an overview of viral hepatitis, really in the context of other infectious diseases and other adverse events and injection drug use. And I want to do that just to describe the rationale and the importance of why we need to engage key populations if we really want to address endemics or overlapping epidemics. And I'll do that by providing some examples of activities centered on key populations. Because it's a short presentation, I'll focus primarily on people who inject drugs. And I'll do that with 3 examples. The first is a pilot of a national survey of syringe service programs, a cooperative agreement to support and strengthen implementation of SSPs, and improving access to services for PWID in settings disproportionately affected by drug use. So this slide shows our current progress in meeting our national viral hepatitis elimination goals. We've seen a substantial increase in hepatitis A cases associated with these outbreaks in 37 states in recent years. And although we've seen declines in the last couple of years, we still have a lot of work to do to meet our 2030 goals. For hepatitis B, we've seen some declines in the last couple of years, but it's still going to take some time for us to understand the impact that COVID pandemic had on artificially decreasing these rates versus actual true declines. And for hepatitis C, we're moving in the absolutely wrong direction. We're continuing to see an increase in incident cases, and we have a long way to go before we meet our 2030 elimination goals. Drug-related overdose deaths have been soaring in recent years, and this is important because injection drug use puts people at risk for multiple diseases and adverse events. A recent study estimated that about 3.7 million people were estimated to inject drugs in 1 year, and a report from the National HIV Behavioral Surveillance System reported that about 1/3 of people who inject drugs share syringes. So I want to take a moment to talk about the people affected by these outbreaks. This is an epi curve of hepatitis A from our nationally notifiable diseases surveillance system. And as you can see, we've seen an explosion in the number of hepatitis A cases. We've had about 45,000 cases during the course of these outbreaks in 37 states. And to give you some background, our average And before these outbreaks in 2016, we'd had about 1,000 cases a year. So these data show the characteristics of people that are affected by these outbreaks on the right. And this is from an MMWR during the peak of the outbreak of data up and through 2020. About 56% reported drug use. Many reported homelessness or recent incarceration, and almost a third had hepatitis C co-infection. And this is important, and I don't want anyone to forget this, that even though we're seeing a decline in cases, this was an unfortunate public health tragedy. This is a disease that is completely preventable with a safe, a cheap, and an effective vaccine. But when you take a virus like hepatitis A and you infect a person who already has a compromised liver or who might have unstable housing, the consequences can be drastic. 60% of these cases have been hospitalized. And we've heard tragic events like liver transplantation and death. To further illustrate this, I wanted to provide an example with hepatitis B. So this slide describes the characteristics of people who died with hepatitis B listed as the cause of death. So on the left, you see this Venn diagram that looks at all deaths with hepatitis B, hepatitis C, HIV, or hepatitis D listed over the course of a decade. And I want to focus in on about the 17,500 hepatitis B deaths during this time period. Of those deaths, a quarter had hepatitis C listed as a cause of death as well. 5.5% reported HIV, and about 1.7% had both hepatitis C and HIV listed among Hep B decedents. So why is this important? If you look at the table on the right, it shows you the age of death of hepatitis B decedents, comparing those with co-infection with HIV, Hep C, or Hep D to those who did not have co-infection. And you can see that on the left side, those with co-infection died at a much younger age. In fact, about 80% of hepatitis B decedents who had co-infection died before the age of 65, which is a much younger age than when you compare to those who did not have co-infection with other viruses. So we're all familiar with the overlapping epidemics of HIV and hepatitis C. This figure on the left is an epicurve of an HIV outbreak in Kanawha County among people who inject drugs from 2019 to 2021. The dark blue boxes indicate HIV infection among people who inject drugs. Among the HIV cases, 86% had current hepatitis C infection, and we've seen this multiple times in many outbreaks, higher than 90%. And the figure on the right illustrates the timing of diagnosis of hepatitis C relative to HIV. The blue lines to the left indicate when a person was diagnosed with hepatitis C before HIV, and the red lines to the right indicate when a person was diagnosed with hepatitis C after their HIV diagnosis. And you can see that overall, hepatitis C diagnosis preceded HIV by almost 5 years, by a median of 46 months. So this relationship has been demonstrated at the community level. In this figure, the authors propose that hepatitis C prevalence could be an indicator of HIV risk among people who inject drugs, beginning maybe at about a threshold of 30% Hep C prevalence. This interval between Hep C diagnosis and HIV diagnosis could be a missed opportunity for prevention if we do nothing, because early intervention in these communities is critical. And it also highlights the importance of viral Hep, HIV, STD, overdose programs working together to provide more of a people-centered approach rather than a pathogen-specific one. So several studies have demonstrated a benefit of medication for opioid use disorder, not only in reducing overdose mortality, but in all-cause mortality. In addition, we've seen the substantial benefits of both MOUD and syringe service programs in reducing both HIV and hepatitis C transmission. And this potential collective impact of these interventions to prevent adverse outcomes of addiction and injection drug use is critical. So I won't go over this slide in detail. Many have seen this or similar slides in the past, but I really wanted to focus on that first icon there with people putting people first. And when we put people first, we're better able to provide more holistic delivery of services. We reduce stigma. We can focus on those upstream policy levers, and we can improve the efficiency and cost effectiveness of our interventions. So I just want to spend a couple minutes talking about some interventions around key populations. And as I mentioned earlier, I'll focus on people who inject drugs. We have 30 or more years of research demonstrating that syringe service programs, or SSPs, are an effective intervention for the health and wellness of people who inject drugs. And we strengthening SSPs is part of a larger initiative at CDC to eliminate injection drug use and associated infections, and reduce substance use disorder and improve health outcomes of people who use drugs. And we do this through increasing coverage, capacity, and harm reduction programs, and establishing surveillance and monitoring. So this first example is a pilot of a national survey of syringe service programs. The main objectives were twofold. First was to characterize and show the impact of reduction, such as understanding where harm reduction services are being offered and measuring the impact of SSPs in reducing adverse health effects of drug use. And the second was to identify gaps in harm reduction, such as looking at disparities in access to SSPs in places with a high burden of overdose deaths, Hep C, and HIV. The survey topics included things like program characteristics, what types of services were provided, the funding for these programs, and community relations and challenges. So this slide illustrates some of the really valuable outputs of this survey and examples of information learned. This was the first time that CDC, together with partners, was able to launch a survey like this of SSPs. It allowed us to build an evidence base to understand what types of best practices, such as employing someone who has lived experience or providing sterile syringes without restrictions, having a better understanding of what types of services were being offered, and also to help identify gaps for where additional support is needed. So the second example is from a cooperative agreement, which is our 2208, which is strengthening syringe service programs. The purpose of this is to increase access to harm reduction services for PWID and reduce incidence of complications of injection drug use in the US. There's two components. The first component is in collaboration with RCI International. It's to support and expand a national network of SSPs and oversee implementation of an annual survey, much like the one I just presented in the previous slide. The second component is in collaboration with NASTAD and is to support and strengthen the implementation of SSPs. So this is the first dedicated funding opportunity from CDC to directly fund SSPs. 65 programs across 31 jurisdictions were awarded a total of $6 million. And some of the short-term outcomes expected from this cooperative agreement is increased access to harm reduction services and supplies, increased testing of hepatitis B, hepatitis C, and HIV among SSP participants, and increased prevention and treatment of infections associated with injection drug use. So lastly, I wanted to mention our integrated viral hepatitis surveillance and prevention cooperative agreement, which is really our core funding opportunity for health departments. The first component is the one that my branch works on a lot, is improving surveillance and outbreak detection. The second is in prevention, increasing access to hepatitis testing, prevention, and treatment. But I wanted to elaborate specifically on component 3, which are special projects to enhance services to people who inject drugs through outcome-focused activities. With this funding, health departments can improve access to services for people who inject drugs in settings disproportionately affected by drug use by developing and implementing a PWID service bundle. So expected outcomes include increased access to high coverage needle syringe exchange, increased linkage to substance use disorder treatment, and increased testing for hepatitis C, HIV, and hepatitis B. Currently, 12 states and 5 cities are funded. We just began year 3 of this cooperative agreement. So this map shows health departments funded in year 2. There's been a couple more who've been funded as of this month. As you can see, the setting types vary by jurisdiction and may include SSPs, health centers, street outreach, mobile or STI clinics, correctional facilities. And some of the examples that our jurisdictions have shared as successes is the ability to build a continuous improvement model for patient navigator assisted screening and linkage to care, or exploring feasibility of embedding peer advocates within correctional settings to facilitate transition back to the community and linkage to services, exploring virtual delivery or telemedicine, or exploring policy changes such as distribution of supplies through harm reduction programs, understanding what it would take in their jurisdictions to be able to do these interventions. So in conclusion, it's the social and structural factors that put people at risk for multiple viral hepatitis and other diseases. And this really just compounds the problem. The negative interaction really can potentially exacerbate the adverse health outcomes of the affected population. And if we could center our efforts not on pathogens, but on people, on key populations, we can respect the person, their circumstances, their competing priorities in life, we're much better able to provide more holistic services, we reduce stigma, and we improve the efficiency and cost effectiveness of our interventions. And these recent investments, although they're not enough, they're a start in focusing activities on people who inject drugs as a key centered population. Will hopefully provide some valuable lessons learned. We'll know how best to optimize our service delivery, inform upstream policy levers that create inequities and eliminate ultimately health disparities. Thank you.
Good morning, everyone. I'm Diane Ballard with the Division of STD Prevention, and I'm here on behalf of my division director, Dr. Leandro Mena, who's on annual leave. So I'm honored that I get the chance to speak with all of you today. And I currently serve as coordinator of our division's EHE activities. So today I'll be sharing highlights from the exciting work that's happening in our EHE-funded STD clinics. But before I dive into our EHE projects, I'd like to say a few words about the Division of STD Prevention. We released our 5-year strategic plan last September, and it set the future direction of our division. The plan includes 5 core values that you see on the slide. And in keeping with the focus of this morning's panel, you can see that equity is one of our division's core values, and it truly is central to the work that we do. Our division works to coordinate STI prevention activities for populations with the highest burdens of disease: adolescents and young adults, men who have sex with men, people who are pregnant, and transgender individuals. To address STIs in the US, not only is it important to incorporate the guiding principles included on this slide, equitable distribution of resources, tailored interventions, and integrated services, but it's critical that we move from a disease-focused framework to one that is focused on sexual health promotion and well-being. Our division is committed to supporting health departments and STD clinics in implementing a holistic approach to sexual health care that facilitates linkage to prevention and care services for co-occurring conditions, including HIV, linkage to wraparound services, and referral to social services. And keeping the guiding principles from the previous slide in mind, let's pivot to the work that I'm involved in the role of STD clinics in the EHE initiative. As I'm sure all of you here today know, the EHE initiative is focused on the communities hardest hit by HIV and is centered around 4 science-based strategies. In DSTDP, we lead projects that support the initiative by primarily focusing on the diagnose, treat, and prevent strategies and their related activities in STD clinics with an emphasis on PrEP. I know this is a familiar infographic, so I won't beat this point to death, but the infographic on this slide is from AIDS View, highlighting something that we're all painfully aware of. As PrEP use has gone up, there's been a decrease in PrEP equity. And so increasing access to and uptake of PrEP is a priority for EHE and our EHE-funded clinics. And this segues into how STD clinics fit into the EHE initiative. Research indicates that STD clinics diagnose more new HIV cases than any other healthcare setting. So they really are uniquely positioned to help people at high risk prevent HIV and people with HIV stay healthy. And a substantial proportion of STD clinic patients belong to key populations disproportionately impacted by HIV and STIs. STD clinics remain important safety net STI clinical service providers because they're viewed as providers of confidential, expert, and inclusive care. And by integrating HIV prevention services into our clinics, we're supporting the EHE initiative and the no wrong door approach that ultimately increases access to quality sexual health services, especially among populations who may not otherwise have access to healthcare services. So there are 2 complementary multi-year projects leveraging the STD clinic setting in support of EHE that I'd like to highlight today. One of these projects is Component C of the Division of HIV Prevention's PS 2020-10 funding opportunity, which is managed in my division. So through Component C, 19 health departments are scaling up HIV prevention services in 26 participating STD clinics to deliver key prevention strategies to populations hardest hit by HIV. And the clinics funded by Component C have focused their efforts on the 5 key strategies that you see listed on this slide. And the other project I'd like to mention is a supplement to our national network of STD clinical prevention training centers that is funded through the Minority HIV/AIDS Fund, or MAIF. This 4-year investment is supporting training and TA to STD clinics for capacity building around HIV prevention services. And the community of clinics that's supported by the MAIF supplement includes those that are funded under Component C, as well as clinics not receiving direct EHE funding. So in total, Component C and the MAFE supplement support 41 STD clinics that you can see on this slide. And those in yellow are the Component C funded clinics. And then the clinics not receiving direct EHE funding are in red. And as you can see, the participating clinics are in the highest morbidity counties for HIV and STIs. Looking at the most recent 12 months of data available, this community of clinics tested nearly 175,000 people for HIV, diagnosed over 1,100 people with HIV, and provided initial PrEP prescriptions to nearly 7,000 people, with over 12,400 of the clients that they served already on PrEP. But let's take a closer look at just the STD clinics receiving EHE funding from Component C. So every 6 months, we receive clinic service capacity and aggregate patient outcomes data from our EHE funded clinics. So the data that you see on this slide and on the next slide are from the most recent 6 months of reporting available to share. Since the inception of Component C, all of our EHE funded STD clinics are able to offer HIV testing at the time of patient visit. 88% can offer linkage to PrEP and 76% can offer ongoing care for patients on PrEP. The aggregate patient outcome data submitted to CDC is stratified by demographic characteristics and population groups in 4 buckets: age group, race and ethnicity, gender, and population group. So this data is meant to monitor recipient progress and not service surveillance data. So the aggregate level data comes with a number of limitations. Of note, we're not able to analyze subgroups, and there are data reliability and validity issues as compared to patient or visit level data. But all that being said, I did want to share a snippet of the aggregate PrEP data. And this, I know there's a lot going on in the slide, so I'm just going to walk through an example from the gender category. So of the transgender patients that are served by the EHE funded STD clinics, we see that a high proportion were tested for HIV and screened for PrEP. So that's the first 2 columns with numbers. And it's not on this slide, but the transgender patients screened for PrEP, of those patients, 92% were found to be eligible. But then when you look in that 3rd column, we see the percentage drop to 31% when it comes to eligible patients that received a prescription. And we find a similar pattern in the data reported to CDC among the different demographics and population groups receiving PrEP services at the clinics. So one thing that I did want to note is that of the transgender persons screened and eligible for PrEP, 33% were referred to a PrEP provider external to the clinic. And that's not on the slide. So what that tells us is that while they may not have received a PrEP prescription from the clinic, they may have received PrEP from an external provider. But even factoring in the PrEP referrals external to the clinic, getting patients from eligible to prescribed is a step that our clinics are working to improve upon. And in the words of one of our clinics, PrEP provision is a delicate ecosystem that is hard to start and hard to maintain. And clinics have faced a number of challenges as they work to integrate PrEP, including barriers that have stemmed from resource and staff diversion to the COVID and Mpox responses. But despite the challenges of the past few years, work is most definitely getting done. And I'd like to share a few examples of activities that have contributed to their progress in the 3 areas on this slide. So to increase HIV testing, clinics have implemented and optimized express visits, which have led to increased clinic volume. They've expanded access to HIV self-tests. They've conducted community outreach, such as pop-up clinics and testing at large events like Pride and during Mpox vaccination events. To facilitate access to PrEP, clinics have expanded their PrEP program by utilizing a nurse-led PrEP model and employing PrEP navigators. They've implemented same-day PrEP, they've utilized mobile units and disease intervention specialists. And to improve linkage to HIV medical care, clinics have increased staff support for linkage to care activities such as hiring staff and embedding DIS to the clinic and so on. They've implemented rapid ART in the clinic, and they've used surveillance data and viral load testing to identify people living with HIV who are out of care. And those are just a very few set of examples to sort of scratch the surface. So many of our EHE funded STD clinics have a philosophy around clinical service provision that's rooted in a syndemic approach. And as the healthcare landscape has evolved, we've seen how they've adapted and incorporated new services to address the most pressing health issues faced by their patients. Mpox is a very clear, very recent example of this. The STD clinic setting is rich with implementation opportunities well beyond the integration of HIV prevention services under Component C. So I've included a few on this slide that our clinics have begun to explore, and I invite all of you to share your ideas and your suggestions with me. Integrating additional services to expand disease prevention efforts is top of mind. This could include implementing status neutral models of care, offering vaccines for Mpox and hepatitis A and B, distributing naloxone and fentanyl test strips at the clinic, and co-locating with SSPs or hepatitis C treatment providers. Clinics can also foster additional community partnerships to increase access to services. Our Component C funding opportunities stress the importance of linkage to other services that are not available at the clinic. Recruiting and retaining staff, the staff needed to support this work, is certainly critical, but will likely continue to be incredibly challenging. Improving the collection and utilization of data through clinic data system upgrades can allow for proper monitoring of service integration and can support program improvement. And clinics can disseminate digital communications that provide comprehensive sexual health messages to raise awareness and reduce stigma. Ensuring that a clinic is welcoming is a component of providing high quality, culturally competent sexual health services that doesn't always get as much airtime. So I'd like to end with a couple of slides that illustrate a unique way that one of our EHE funded clinics engage with their community to make their clinic a more welcoming space. So the San Francisco City Clinic is a sexual health clinic that sees about 250 patients a week, mostly between the ages of 20 to 40, and many of whom are uninsured. They were exploring ways to improve the physical infrastructure of their clinic to enhance value for their patients. Art can create a safer, more supportive environment that can reduce patient stress, improve health outcomes, and also increase staff satisfaction. So through a community engagement process that involved current staff and patients, as well as the extended community, the clinic collaborated with artists to create a mural that is a very, very special tribute to their community. And here you see the 50 by 50 foot mural that was unveiled in late 2022. It's beautiful, and it's also very rich with symbolism. So you see the tree roots that are intertwined with the flowing water at the bottom of the mural. Well, we can't in this room, but those online can. And that's meant to represent fostering healing. And birds of all kinds represent the diversity of the clinic's patients. The sunset forms a multicolored triangle representing the LGBTQ community. There are fish swimming upstream that symbolize strength and perseverance. And we can't see it in this image, but the word welcome is written in different languages to the right of the front door to greet patients as they arrive. Thank you for allowing me to present today. If you have comments, questions, or any emotional outbursts, there's my email.
Good morning. I'm really glad to be up here because I was sitting right under a blower with Demetre, and we are very, very, very cold. My slide should come up in 1 minute. I'm Laura Cheever. I'm the Associate Administrator of the HIV/AIDS Bureau. I'm here today with several of our staff, including Heather Hauk, our deputy, who is the person in charge of EHE for our organization. Just to start, the Ryan White program, I think as all of you know, is essentially, in the way it was structured and run, a health equity program. And we've always viewed it that way, but have been more intentional about our efforts around equity in the last 12 or 14 years since we really saw our data about where our disparities lay within the program. And so we have a 5-pronged approach that we are intentional about. First is community engagement, which you've heard from several people already. I'll talk a little bit more about our most recent activities. So we get good data and input from our community, and then we change our actions based on those inputs. We also utilize data. Similarly, we look at our data and take action based on the data we see. Some of that work we do through continuous quality improvement. And I think some of the disparities that we've had in specific clinics, we can actually track back to specific quality collaborations and quality engagements that they have undertaken. We came upon implementation science sort of in a backward way by seeing our data, knowing we had to do something differently, and then figuring out how that gets done. And an effective way of doing it is actually through an implementation science framework, which we've used and I'll talk about. And finally, and I think really importantly for us, is our program from its initial architecture included both essential support services and medical care. So we do have some ability to address some of the social determinants of health embedded in our program, things like being able to pay for transportation, food, and housing in a limited way. So just a really quick review of our data here. Our program serves over 500,000 people every year. I want to thank you all because you do so much to get us these data that help us talk to people about the success of the program. That's over half of all the people diagnosed. And in the last 12 years, we've significantly improved our viral suppression rates among people in care. And some of that is because the drugs have gotten easier to take, but a lot of that is really because of hard work that you all have done to really focus on those gaps, particularly the health disparities we had. That said, about 12% of our people do not have stable housing. About 60% live below the federal poverty line. Our populations are aging, which are bringing on different sorts of challenges for us. And about 3/4 are racial and ethnic minorities. So we're able to document our program is actually reaching the people that are most impacted by this epidemic. So this slide is busy, but I'm going to spend a minute on it because it's important. This is a slide that shows viral suppression rates in 2010 in the dark blue compared to 2021 in the lighter blue by key populations, which are covered by that annoying box at the bottom. But anyway, so on the first slide, you see, I know what they say, but you all don't. On the first slide, you can see our overall rate increased from about 70% to 90% over the last 12 years, which is about a 20-point increase. So congratulations to all of you for the work that you've done in that. Absolutely. But when you look at some key populations across the bottom, and I'll start with the one with the first red arrow, which are African Americans, you see we had some significant gaps, and we've made improvements in all key populations, but we've made bigger improvements in the overall viral suppression improvement for the country. So we've reduced the disparity gap for African Americans by about 4% greater than that, which is occurring nationally. Our biggest gap has been in, well, the next group is, are you moving that? I don't know what they're doing. Okay. So regardless, the next group are transgender individuals, which have also increased significantly. The biggest improvements we had have been in youth, and that is a group that we actually started with some projects that Harold led when he was working with us. I don't think I did that. The group that we've made the least improvement in terms of reducing disparity gaps is among the unstably housed. And I think the bottom line there is that you need to be stably housed. Emily cannot be laughing in front of me. That's not fair. When we look at our priorities similar to other people, I'm going to talk about some of our overarching priorities, and I'll talk about these in some more detail around implementation science, community engagement, and syndemics. So community engagement is something that is really baked into our program in the sense that we have planning councils and other legislative required engagements of people with lived experience. We had heard in multiple community engagements that that people with lived experience often are not paid to be at those tables. And for all of you who have been parts of planning councils, I have, they take a tremendous amount of time and effort. Many of the people sitting there are paid to be there. And so our statute prohibits direct cash payments to people who are receiving services through our programs. So we put out a program letter this year talking about all the different ways that our program can support in community engagement activities and being able to to reimburse people for their lived experience and what they're offering. It can't be done through Ryan White funds, however, that last point. Once again, we haven't reauthorized our legislation for a long time, and that is part of our statute. We also do engage in community listening sessions. In 2019, our staff visited pretty much every EHE jurisdiction to talk about what we plan to do and to hear firsthand from people. It significantly changed the way that we were organizing our work, both in terms of the NOFA we wrote as well as our internal work. So we really appreciated that engagement. In 2021, we had virtual engagements by region, and we've done those in two settings, first with the public health leaders and also with community in each of those regions. We are going back now in 2023, and we are doing this in concert with CDC. We'll have regional-based community engagements again at that same structure. So we're really excited about that. Much of the work we've done, we can trace back to significant input we've received from both you all and from people with lived experience. One of the things that we've done as a result of that community engagement is figured out how we can get capacity building and really bringing some of our model building into community-based organizations that might not have the wherewithal to be applying or receiving, be competitive for federal funding, given all the professional grant writers and everything else that occurs in the world. So we have a SURE initiative where it's a SPINS initiative where we funded an organization through a competitive process to then fund smaller community organizations to institute models to reach people we weren't successfully reaching. So in the case of the SURE initiative, we funded an authority that works with housing, and they are funding community-based organizations to develop better models and to really look at evidence-informed models of people with a history of incarceration, people who identify as LGBTQ, and youth and young adults, because there's three groups that we, looking at our data, knew were not necessarily, that housing was an increasing impediment to being able to do things they need to do to take care of their health. The E2I initiative, this first part of the initiative is ended. This was really, I think, our flagship of really looking at implementation science in a structured way, where we once again funded someone through a competitive process. This was Fenway, who then funded a series of community-based organizations to institute evidence-informed interventions that those groups decided were the ones they wanted to institute and would be the most practical and sustainable over time. So key populations included transgender women, Black men who have sex with men, integrating behavioral health, specifically MAT in many cases, and identifying and addressing trauma, which is really, I think, a root cause of many of the kind of barriers that people have to fully engaging in care. Now we have the next version of E2I, which is 2IS, where we're using that same process of funding one organization competitively, and they're funding community-based organizations to focus on, and you'll see this, we have a new theme, you saw this in SURE as well, people with a history of incarceration, LGBTQ youth, once again, working on substance use disorder, which continues to be a big problem, as we've heard from other people speaking here today, as well as being more mindful about how we integrated telehealth. I think everyone had integrated telehealth, but how do we do it in a much more patient-centered way and not just in the response to an acute emergency. We do have a SPINS project that's more traditional around people aging with HIV. Once again, a key population that do very well from a viral suppression perspective, but really have a lot of unmet healthcare needs and have other significant disparities around comorbidities. And we are just wrapping up Black Women's First initiative, which was another sort of initiative based in implementation science. And specifically, we heard from women that sort of the siloed one intervention approach was not working for them. So this is actually more complex engagement or using bundled interventions to better reach women. When we are focusing now specifically on syndemics, I think in the Ryan White program, we do have the luxury of being able to have a more syndemic approach to our care, as you saw from many of those previous interventions. But this year we've released this year and late last year, a series of program letters. One of the more recent ones was to really encourage Ryan White programs to be better addressing STIs and monkeypox, specifically for you all in the room, that there are some ADAPs that don't cover treatments for STIs. And so patients, uninsured or underinsured patients in a Ryan White clinic might need to therefore go to a sexual health clinic to get treatment. And how can we do that a little bit more seamlessly? So we really do encourage you to consider that in ADAPs for people that don't have other healthcare coverage. We had a letter around the housing status and HIV outbreaks. From the data you've seen previously, that many of those people with HIV do have homelessness as an underlying factor that needs to be addressed. We've put out a letter about how Ryan White fits into the status neutral framework. We think it's a great idea, but our funding is really very, very restrictive if someone does not have HIV, but certainly braiding funding is something that can and does happen at your level really successfully. So we just wanted to clarify that for people. And the most recent letter we've had is one directed towards ADAPs, really focusing on considering adding buprenorphine and naloxone to your ADAP formularies, given the ability to really expand now access to buprenorphine for populations. Ending the HIV epidemic initiative. So you've heard a lot about this already today. I will say, once again, Heather Hauk right here, she's our lead, so all questions should go to her. But you guys have done great. I mean, really fabulously, because even during that first year, we were able to document incredible success in new partnerships. You really were super flexible given everything else that was going on. We gave you that money in March of 2020, not perfectly timed by us, but we didn't know. So really innovative programming, focusing on the newly diagnosed and those re-engaging in care. So we have really focused this not on people that are in care that might have other unmet needs if they're virally suppressed, but on people that we haven't yet reached. And you guys have really risen to that. Different expanded partnerships include a variety of clinical organizations like pharmacies that you might not have delivered services before, non-clinical organizations, including syringe service programs that we talked about earlier today, jails and correctional facilities, and then non-traditional partners, including faith-based organizations, restaurants, barbershops, really the gamut. So with that, I'll end with some key resources we have, data, a bunch of great data reports, data slides, and importantly, check out our Compass dashboard for data visualization. And that's my contact information. Thank you all very much.
Y'all didn't hear me, but I just said, wow. We actually made it through 135 slides or something like that, and right on time. First of all, thank you to all of you for really the great information that you shared. And actually to following instructions and sticking to focusing on key populations and the priorities around syndemics. So I actually I have a question to start around coordination. And Harold, I'm going to start with you, but I'll put others on notice. Each of you appropriately talked about your division or your area in terms of the syndemics, in terms of work with key populations. And what I'm sure others are interested in knowing is how are we going to coordinate across those various divisions. So Harold, let's start with you in terms of coordination across the agencies, the federal agencies, and any thoughts you may have around or opportunities you may have around coordination of all of the work that's happening across the various agencies as it applies to either the syndemic approach and or work with key populations. And then maybe Robin, I'll start with you at the CDC level as you look across division of prevention and viral hepatitis and STIs, opportunities for coordination, and certainly Neil and Diane, you can chime in as well.
So thanks for the question. I would have to say that I think that the federal agencies are probably coordinating in new and different ways and more frequently than we ever have before in the past. I think and that's a result of several things, both sort of thinking about and approaching this endemic differently. I would say having a White House Office of National AIDS Policy to be able to bring not only the partners that are involved, partners and agencies from HHS, but also HUD and the Department of Agriculture to the table, really thinking about the role of the Department of Justice in all of this as well, and getting their involvement and engagement. So in terms of collaboration, I think several things, specifically outside of many of the things that you heard in the presentation. We're currently working with our partners at HUD because HAPWA, which we talk a lot about, is a very, very small slice of the overall HUD budget. And we're not going to end our HIV housing crisis by just focusing on HAPWA. So we've worked with the Secretary's office to think about what is the role of the other programs and how do we make space for people living with HIV within those other programs like public housing, like Section 8 as well. We're also doing some work with the Department of Labor to really think about their programs which impact individuals that are living with HIV, and how do we also sort of create pathways for people both at the federal and the state and local level, which administers many of those employment programs, to be able to do this as well. And I would also add to this that we're also working with OMB to see if we can put out better guidance around how to blend or braid rather different funding streams to be able to address intersecting issues.
Awesome, great. Thank you.
Thank you, Stephen. I'd say for us at CDC, first our center is taking a huge leadership role when it looks at the coordination among divisions. I think for us specifically in DHP, something that's new for our upcoming NOFOs is really thinking about syndemics and making sure that we have representation from DVH or the Division of Viral Hepatitis, from the Division of STD Prevention, to ensure that, as we're thinking about our conceptual framework, we're thinking about it through a syndemic approach, making sure that we have representation from those divisions. As is illustrated here, I think a lot of the incredible work that we do is service programs, STI clinics, implement really innovative syndemic models, and then as Neil described the response activities that we do. I've never spoken as much about hepatitis as I do than when out in the field and responses. And I'll just say also in DHP specifically, our leadership, I'm thinking about Dr. Andrew Hernandez and Dr. Buzz Prejean, chiefs for our surveillance branches, have been thinking really critically about what syndemic approaches look like when it comes to surveillance.
Yeah, just to add, I think we go to work every day and we do our job. And, I work in the Division of Viral Hepatitis and my outcomes are viral hepatitis specific. And it's just natural that that's what I'm going to be focusing on. But we really need to change the orientation of how we come to work every day. And I need to think about population health and who I'm trying to help. And it's just natural that, we are where we are today. But I really think in recent years in particular, I've seen intentional activities to try to break through those silos, because that's just how we've been organized for years and how funding comes from Congress. We've got to get beyond that. Robin pointed out, in our center in particular, I think we do a good job, although lots of room for improvement for us to work across divisions. I think if we did that more, we would find efficiencies, we would get valuable lessons learned. And so I think, using surveillance as an example, I love the National HIV Behavioral Surveillance System. I mean, the focus is on people every cycle. It's a population, and it's really trying to understand other determinants and behaviors of that population. And so to the extent that we can expand, understanding viral hepatitis prevalence in those populations and not being limited so much by every year, we're always struggling to find the right resources from different pots of money. And the more we can think creatively about breaking that, I think we can more efficiently understand the needs of populations. In addition to that, with COVID, I think helped us as an agency. Our divisions come together looking at data sources, data systems, cooperative agreements, getting vaccine out to people who need it. And I think we're working a lot more collaboratively. I think, for example, there's a group that's now being stood up in the response center at CDC that's going to be focusing on key populations. And I reached out to them before this presentation just so I could learn a little bit more and share what they're doing. So there's going to be a focus on key populations. It's going to be response focused, but for example, some populations will be homelessness or corrections, and really trying to think about how to bring together experts in the field to address not just hepatitis C or HIV, but also Candida auris, lice, Giardia, things that affect populations, and being more thoughtful about how we engage our subject matter experts with other agencies. And then lastly, of course, other agencies, we're working with SAMHSA, with HRSA, and trying to understand how we can better utilize resources to improve outcomes for populations.
Awesome, great. Diane, anything to add?
I would say that I think, I know on our end that we've worked much more closely and collaboratively together through EHE, through Mpox, especially with Division of HIV Prevention. I know that we've had so many standing meetings as we develop funding opportunities now and into the future. We're able to consider everything holistically, but also something that I've been trying to focus more on, and I know the others in my division, is really learning from our recipients, because they've been doing this for a long time. They all know what you're doing, and when we pause and actually listen to all of the intelligent, insightful information we can gather from our recipients, I think being open to that and being able to incorporate that into our funding opportunities, into our work is something that we need to continue to do and to elevate. So.
Great, thank you. Laura, anything from your perspective?
I just want to give you two perspectives. One is in terms of working with federal partners. I think we try to be pretty porous. Like, we don't have a lot of ego needs about like keeping all the HIV to ourselves. And so that's not true across all the agencies, but I'll just say that. So so it really is about like having standing meetings. We have a standing meeting with the Division of HIV Prevention on a quarterly basis, and certainly Robin, we talk to Robin or Heather regularly about this or that is coming up and how do we do this or that. And so that's certainly something that I think is natural for us. The place, and with Papua, we have a very good relationship with Papua. Bigger HUD is part of CRAC, where we've had our challenges, I think, has been with SAMHSA, just trying to find the right people to work with SAMHSA who are going to be there in another 5 years and, you know, have some history and can really help us. We have been largely unsuccessful there, I will say. But within HRSA too, HRSA has just a ton of programs, you know, $12–13 billion worth of programs in HRSA on the sort of public health side of things, not counting provider relief, which is a whole different thing. But so I'll give you some examples when we're working around all the EHE work has really been in conjunction with BIPIC. We've worked very, very closely with them. When we were working with around breastfeeding and making sure that breast and chest feeding and the new guidance was quickly disseminated, we worked with Maternal Child Health Bureau. We've led efforts with Office of Women's Health, the Federal Office of Rural Health Policies, of the HHS Office of Rural Health, actually it's HRSA, we work with them. So they really helped us. And obviously BIPIC is not just the traditional health centers, but the healthcare for the homeless. They have a huge reach there, migrant health and school health. So we work with them a lot, all the time on all sorts of things. So they're just a couple of things. Like right now for HIV Indian country, I mean, not HIV, but STIs in particular, Indian country, within HRSA, we're leading up the effort within HAB, but once again, engaging those same group of partners, because there's a tremendous reach that we wouldn't necessarily otherwise have so fluently if we didn't have that sort of ongoing engagement.
Great, thank you, thank you. Demetre, actually, this is for Demetre and Laura. Demetre, I loved your slide where your toolkit for Mpox prevention, and I noticed the vaccine was a hammer. And I don't know if that was intentional in terms of your picture.
And behavior was a screwdriver.
And behavior was a screwdriver.
I don't do anything by accident.
But as we talk about vaccine, Laura, it reminded me, and you didn't mention it here, but I think I've heard you say before that HRSA got some vaccine and those were distributed to Ryan-wide clinics for distribution. So maybe we can talk a little bit about the opportunity there for increased administration of vaccine, maybe for you, Laura, specifically through the Ryan-wide programs, but Demetre, anything else you want to talk about or discuss as we talk about increasing vaccine uptake?
Sure. So I'll start that HRSA was actually just one of the recipients through the federal channel that was developed for Mpox or Jynneos vaccine. So that also included the VA, DOD, the State Department, et cetera. So there's a lot of different places that sort of went directly from ASPR through the SNS right to federal partners. So I think obviously, I think the importance of the HRSA channel is not only in the Ryan-wide space, but also in the VIVIC space, as we were just talking about, the sort of idea of really providing direct reach. I'll also say that it is only a partial view into what happens, because beyond the sort of federal channel of vaccine that went to HRSA, local health departments also provide vaccine to those same FQHCs. So it ends up being, and also Ryan-wide providers. So depending on the channel, there are multiple doors that lead to vaccine access for folks who are living with HIV or those who can benefit from prevention. I'll say that, obviously the sort of syndemic tale that I told of how we actually saw Mpox entering the syndemic really reinforces the importance of blending Mpox prevention and Mpox work into status neutral and sexual health frameworks. So I think you already heard that from Diane and again from Laura, but ultimately, the flexibilities that were created to allow for resources to be used to increase Mpox vaccine uptake, they didn't expire with the PHE. The public health emergency is over, but all of those flexibilities exist. And so sort of rekindling sort of the effort that everyone did over the last several months to sort of make a push for the Pride season and the other festival season really becomes critical. I think Laura and I have had lots of communications and discussion around this as well in terms of ways to scale up. But it sort of reflexively sort of asks the question, how's vaccine supply? Just fine. So that's the other important message, that vaccine is adequate and intradermal route as good as subcutaneous route. We should definitely sort of lead with intradermal, but really give people what they want if they're asking for a non-intradermal route. Also realizing that behind the scenes, there's adequate supply if we should happen to have increased demand. Laura.
Yeah, so I talked to Demetre a lot, probably at least weekly, maybe more, about Mpox and things that are going on. So the Ryan White program was offered to be able to distribute vaccine, and that was, of course, the week we were having our national conference. But we just proceeded, and we did it really because initially we had a very limited amount of vaccine given to us, and because the supplies were so limited. We actually focused, and we wanted to get it out as fast as possible because we were trying to really avoid that rise that you saw. We initially focused on Part C and D clinics. We have a direct relationship with them, who had a significant number of men who have sex with men as clients in the program. So we were able to ask those who wanted vaccine in what quantity, get that vaccine out to them within a week or two of finding out we initially had received it, because we thought it might be coming, so we were doing some planning. And then we continued to offer to more and more of the Part C programs over time as we had increasing amounts of vaccine. And right around the time we got it was actually when it switched to intradermal. So we had a whole different volume, but a whole different sort of volume of vaccine available in terms of number of people to distribute it to. So that was really exciting. Many health centers or Part C programs that we offered it to took vaccine, but many of them were already getting it from the state, and they said that we were getting it from the state. And those that got it both from us and the state found out when they got it from us, they had to report it into the whole federal reporting system. And then they said, we're actually getting enough from the state now. I mean, when they were, and so we don't need to get it from you anymore. So we have not had people really that interested in getting vaccine from us recently. I think we've had 2 clinics reach out to us that wanted more vaccine, but most of our Part C clinics have not wanted vaccine because they feel that they have systems set up to get their clients vaccinated, mainly through state resources or other municipal resources. So it hasn't been an ongoing need so far, but we continue to offer with our concern about Chicago. I immediately called up Howard Brown and said, do you need more vaccine? And they're like, no, we have vaccine from other places. So thank you. They took it initially, but at this point they had enough. So that's sort of been our vaccine story. The other thing I'll say that was so interesting is we had at the CDC Grocery Advisory Committee, we had people talking about our vaccine, their vaccine experience, and we had a clinic in Sacramento that had started out as an aid service organization serving African Americans, and had grown into eventually an FQHC that was really still African American focused, and they were part of this vaccine effort. And they started distributing vaccine. At this point, it's August, so the disparities had already existed, and they knew about them. But when they looked at their data after about 3 weeks, they were giving only to white people. And they're like, how did this happen? Because, they were distributing to their patients with multiple patient networks. And they actually, this organization that was really grounded in the African-American community in terms of leadership and origin, still had to find other African-American community organizations to help them distribute the vaccine to the right people. And that was just telling me, because I'm like, no, this is the type of organizations we're trying to grow. And they were grown, but even in that setting, they had to find that next level down of more grassroots organizations to reach the people they needed to reach. So I think that was very instructive to me as we move forward.
just to add one quick thing on that, which is, this is one of the reasons that we also approach SAMHSA effectively, actually, as well as HUD, realizing that the Ryan White does amazing work and CDC does amazing work in the prevention space. The people who are having the most severe outcomes were neither touching CDC nor HRSA. And so, sort of they were, however, touching drug user health, substance user health, as well as housing resources. So those flexibilities were really designed as a partial equity intervention to reach the folks who were not coming to service in the sort of routine HIV spaces.
Awesome. Great. All right, I'm going to ask one more question, but I'm giving folks in the room a heads up, or folks in the room and folks online a heads up that please feel free to come up to the microphone, ask questions. And then for folks online, if you want to type your questions in the chat box, we'll have someone read it on your behalf for us. So my next question, actually, Diane, I'm going to start with you and go this way. Let's mix it up a bit. But this is about just COVID-19 and some of the responses and that all agencies and all divisions kind of put in place in response to COVID-19. And as the public health emergency is unwinding, what strategies, approaches, interventions that were implemented within your division that will continue moving forward?
Not an area that I worked on specifically, but I do know that through the GIS workforce development funding, so part of the COVID funding, that was a massive investment to support the expansion and just the enhancement of the GIS workforce, which has been so critical in COVID-19, was also with Mpox. So I think that from what I gathered, there was some challenges in being able to spend all of that money, but I think that the improvements that can come from recruiting, training, outbreak response that comes with that money will be able to support all of the ongoing syndemic efforts, to be honest. And I think that we've seen some examples of how some of this work has already played out in certain health departments that have been able to develop career pathways to be able to retain the excellent DIS they're able to hire, using modeling to help guide some of the work that DIS is doing in the field. And so certainly that's an area that our division has been managing and working with recipients to be able to spend that money and do the best they can.
Cool.
Well, obviously, there were so many innovations that happened acutely with COVID-19. We received a relatively small amount of money and distributed it immediately when we got it, the very first wave of funding. And people use that money for all sorts of innovative things, and then those innovations are going to persist. I think telemedicine is the first thing. I think people did all sorts of different things with telemedicine. Some organizations gave cell phones away so people could actually do telemedicine. So a lot of innovations there. I think we saw a lot of innovations around delivery of medications, where people allowed 90-day supply of medicines for a long time. I think some of them are still continuing back to see how effective it is when people now tend to be on their same antivirals for years sometimes. So that's going on as well as home delivery and just making it more person-centered. The use of the rideshare programs happened as a sort of safety thing, but people saw how effective that could be too. So I think that's continuing beyond the usual sort of taxi cab. I think one of the most important things, and it happened both for us and for you all, I think, is really thinking about certification and recertification and dropping some of those barriers. So some places require people to notarize their applications and recertification, and that's a huge barrier. And some of those drop. Being able to sign forms electronically and figuring out how to do that from a cell phone and other ways, I think is important. Doing things, attestation over the phone, all sorts of different things, being able to link to other data sets so you don't have to get primary data from people. I think that has been really important because that recertification, and we actually, so Andrea Jackson is here, who led our PCN around recertification and really getting rid of that 6-month hard stop. I think is probably one of the most important things that we need to do is we just keep kicking people out of our program and they end up with really bad outcomes. And so how can we do that differently? And I think that was a big innovation that that we are encouraging people to continue, and we're continuing to work on it right now. We're continuing to work, NASTAD has been a partner in this, on how to simplify some of that. What is the most person-centered approach we can have towards getting in our program, staying in our program.
I'm going to jump off the CC line for something that maybe you all don't even know about, which is that one of the sort of COVID innovations that crosses so many of the syndemic areas that we're talking about is diagnostics. And so in NIH, RADx and FDA and NIH ITAP, which is the program that accelerates diagnostics that was developed with COVID, they're really interested in HIV and STI, like really interested, because it gives them a sort of mission to continue after we're done with the sort of COVID diagnostics. So we're working with them Mpox side to develop multiplex testing for lesion-based tests, including syphilis, HSV1, 2, VZV, as well as Mpox. So it's an opportunity that will persist after the public health emergency ends that this room needs to tap into.
I'll just give maybe two examples. As a small division, I think it's hard to build out new programs, but it's really about how we maximize what resources are available in the agency and strengthen our partnerships. So one is a surveillance example. I think, first of all, there's a lot of activities going on right now with data modernization initiative and how we receive data. And so it's really trying to understand how they improve the flexibility with how data are received by states. I would say right now it's a lot of work to think about what that future will be. But also in data science. So there's been a lot of improvements in visualizing data, bringing a pipeline of data in, and then making it visible for health departments for public health action. We're really excited about that new initiative that we've been able to capitalize using this cipher, which was what this built, the COVID data tracker, if you've seen it online, will be for the, for our first time pulling in a pipeline of data for viral hepatitis and having health departments see it almost real time, what we're seeing, so they can see not only the epi, but some of the data quality. And it's amazing that we're doing this. A few years ago, we were still emailing line lists for hepatitis A outbreaks. So this is a huge step forward because of the investments made during COVID. The second thing I just wanted to comment on is vaccines. So when we had national calls for hepatitis A outbreaks during COVID, and I kept saying to health departments, lean in, call your immunization program, because they may not know. You are the ones, you are advocating for populations that need help. Corrections agencies, people experiencing homelessness. So make sure you reach out to them, because they may have resources for immunization programs, but don't know how to get it to the people who need. And so there's been some improved collaborations with our immunization services department and the vaccine ambassadors program that's really understanding vaccine barriers, and not disease specific, not just COVID or Hep A or B or Mpox, but what are barriers to providing vaccines in places like certain service programs or corrections. And I think these are just examples of how we're thinking outside the box that we did maybe a few years ago before COVID, where we're really trying to think about expanding beyond our pathogens.
So I think just to piggyback a little off of what Laura said, it's really about patient or person-centered care and ensuring that they are able to receive it where they want, when they want to. I think in addition to this role, I also serve as a provider, and I would just at the VA, and I would just say, within a week, we had to go to telehealth and telemedicine, which was a completely different model. And even now, 3+ years later, there are patients of mine that want to continue that. They enjoy being able to get their labs when they want to, and then be able to kind of sign in at home. So I think when we think about telehealth and teleprep, that's something that I really think is going to be here to stay. I think for us also, when we think about self-HIV test kits going to the home, our new iteration of Together Taking Home, it launched about 2 months ago. And there's so much interest in this. I think it really, once again, speaks to individuals wanting more control over their healthcare and when they want it and how they want to access it. For National Transgender HIV Testing Day, I had the opportunity to utilize Together Taking Home, have it mailed to my home within 2 days, and be able to take it in the comforts of my own home to actually see what that process was like. And our data really shows that people act on the results, whether it's negative or positive, that they do act on the results. So I think that self-testing is something that will also be here to stay. And the final, I would say, is really the expansion of mobile units. You can see that almost half of the SNPs that EHE funding has supported are mobile units. I gave the example in Detroit of mobile units going into the community to provide gender affirming care. So I think once again, breaking down the traditional brick and mortar and just being able to go into the community and meet people where they are with how they want to receive care, hopefully is here to stay.
So I guess for me, because I don't run programs, I approach it a little bit differently in that I've sometimes said that COVID-19 is sort of like having one of those diagnostic dyes injected into the system, because we were able to see and understand systemic racism on a whole different level when it came to COVID-19, as well as the impact of social drivers of health. So really sort of using those examples to push for policy change, really thinking about future pandemic preparedness and what's the role of the HIV and STI community and our infrastructure, and how can we be sort of planned and included up front as part of that overall national response and not as an afterthought like we saw with COVID-19. So really thinking about what are those DIS investments that are needed and having those conversations. Of course, the acceleration of EHE and its funding, but also thinking about the role that the private sector played in being a trusted messenger when there was doubt in government, and so engaging them in this piece too. Also, the lessons learned about the role of pharmacists and how they helped us achieve health equity when it came to COVID-19, really carrying that forward into our HIV work. So a lot of the work on PEP and PrEP and understanding sort of the complications of scope of practice and payment for pharmacists is one of those things. And then, as has been said, sort of the innovative approaches, both the implementation science, ensuring that that's embedded in our work, but also the role of technology and telehealth flexibilities and self-testing and combination self-tests as well with STIs. And those are the pieces that I think are really important as we sort of move forward from COVID-19, but take some of those lessons and approaches with us.
Cool. All right. Actually, why don't we stand? Why don't everybody stand if you can and if you're able? Just to, especially for those of us here at the front where we have the ear is like beating down on us. Feeling cool. Stretch. Just want to make sure we get our juices flowing and I looked out and saw a sea of folks that were looking a little sleepy. All right, thank you, everyone. Let's take our seat and we can. All right, I see Marlene is up at the mic. So Marlene, go ahead. Can we turn the mic on, please? Try it. No, it's not.
Hello?
Yes,
There it
here we
is,
go.
okay. All right, good morning and thank you all for your presentations. Marlene McNeese, Houston Health Department, and I really just wanted to really tout some of the biggest local EHE successes I think we've experienced. And I appreciate Harold's comments about we need another way to elevate and escalate some of these stories. And I really just wanted to start with you, Diane, because the 2010 Component C funding has been one of the biggest game changers in Houston locally. Yes, one of the things that folks may or may not know, but we are the only, I believe, directly funded city for HIV that is not directly funded for STD. So for years and years and years, of course, we work with our state partners on some of that work, and most of our sexual health clinics are locally funded through general tax revenue, so woefully underfunded living in the state of Texas. So through Component C, we were able to apply, and we've had tremendous growth in a very short period of time. It's been miraculous. So routine bundled screenings, re-engagement specifically for women of childbearing age in completing syphilis treatment, same-day PrEP. There's just been a radical amount of work that's happened. And we really got a lot of that support through the technical assistance provider through Denver Training Center. And we know that that contract has come to an end. And so really just wanting to put a plug in. I know the mechanics around the mechanisms for how 2010 or EHE funds will continue and funding announcements moving forward will change. But I just wanted to put a plug in for training centers because they really took a place like ours that's just been woefully, I think, behind the curve and really skyrocketed us light years into the future. And I just want to say one more thing about viral hepatitis. So we also were an awardee for 2103. And again, we've been able to leverage beyond what we do in our clinics through A and B vaccine, but really for the first time, a place like Houston, Texas is beginning to think about treatment for viral hepatitis in these clinic settings is beyond miraculous. We're also working with NASTAD around an SSP determination of need. Again, there's lots of work going on in Texas, but because of these some challenging policies, there's not a lot we could do. But I do think a lot of the work grassroots organizations have been doing can be undergirded and supported. So we're really, I think, leading that in Houston and for the state of Texas to move to that way. And we only could have done that because we were able to undergird and bolster what happened in our sexual health clinic. So I just wanted to give those success stories to the two of you to share. Thank you.
Good morning. Jacqueline Clymore, North Carolina. It's wonderful to see you all, especially some familiar old friends and some maybe newer faces as well. And it's good that Marlene kind of led with the positive stuff because I'm actually standing here to express a couple of frustrations as happens with this. But first, to the point about the importance of telemedicine, you know, we have worked particularly in HIV for 30 years to overcome the issue of transportation in rural care. Really hard to do, really difficult to solve. Ubers don't exist when you're way out in the middle of nowhere. Families don't want to or can't transport people to care. So I agree that COVID was a huge injection, to Harold's point, of the die that showed what things work and what don't work, and telemedicine was one of those. And I really hope that insurance carriers are going to continue to cover that. We're starting to hear some things that make it sound like telehealth could become shakier depending on how you're insured. So I worry a lot about that. It was exciting to hear about all of the PrEP initiatives and the national PrEP plan and all of that. But one of the frustrations, and I heard this in our meeting yesterday with high incidence areas, cities and states, we still can't cover provider care, provider time. If you're not an EHE funded jurisdiction, there's still a gaping hole there. And we can't get our FQHCs very engaged in the idea of PrEP care. I have even funded.
We've lost the mic.
I even funded doctors to provide PrEP at an FQHC in Raleigh. The FQHC did not want it. Thank you. The FQHC didn't want it. So in the end, it was a failed effort. So that issue of making sure that medical providers get reimbursement for PrEP care is really critical. The last thing I'll say, I'm going to keep holding this. The last thing I'll say, you all have talked so much about engagement with housing and engagement with HUD. And that is incredibly exciting, but also we're pretty frustrated. We in North Carolina are still using up a lot of our HOPWA funding from 2019 because we can't get it spent because of the issue of fair market rent. 3 weeks ago, my office sent a memo to HUD asking for an exception about the fair market rent issue. We haven't even heard a thank you for your letter, much less we'll work on it. We're doing something, we hear you. Nothing, zero. We can't get the money spent, especially given the cost of housing and rent these days, because there's no one who will accept the idea that HOPWA funds don't have to meet the fair market rent issue. So we're failing in keeping our clients housed. I have 150 clients who are waiting for housing in North Carolina through HOPWA, and money isn't the issue. That's not something we get to say very often. We've got plenty of money. I could house these people money-wise, but there's no place to put them because of the fair market rent issue. So please, please engage HUD and chat with them about this issue, because I know that North Carolina isn't alone in this. And thank you all. This has actually been very exciting.
I'm looking if anyone has any.
Yes.
And actually, I think this came up, Harold, at the housing roundtable that you CDC had hosted 2 weeks ago. So
fair market rates, and that there is a process for exemption that was mentioned in that meeting. So I will follow up with them on that piece as well. I will also follow up with some of our colleagues on DPC who are leading some of the telehealth and telehealth flexibilities issue and working through those pieces too. So thank you for that.
any other questions, comments from folks in the room? As you can see, these guys are thick-skinned. They can take feedback.
And Jacqueline, and hopefully I will have an answer by May 31st when I'm in North Carolina and Raleigh. So I'll bring you an answer. That's my plan.
Good morning, Elaine Martin from Virginia. Having just finished a few months ago our 5-year integrated plan, I do want to give some feedback. It is very difficult to plan 5 years into the future when we don't know if we're going to have money in January for HIV prevention. And that I know we've had dialogues and we've had meetings, but the answers we're getting are not transparent. I'm sure there's something going on that you can't tell us about, but we cannot plan. I can't sign a contract for 2024 unless I know our procurement won't allow that we're going to have money in place. And everything Jacqueline said, I also echo. FQHCs in Virginia are not interested in providing PrEP even when we offer them money. So I'm concerned about that. There's still that lack of a provider payment system. And then if new money coming out is only going to FQHCs, that's not going to help us. We need money for STD clinics to provide those services. So we have one-stop shopping in-house. Workforce is still a big issue. Our HIV testing is still down by 50% because we can't find nurses to staff the STD clinics. So our local health departments are not providing the STD clinics like they used to. So, that's a concern. And so you then attempt to pay people more money. Cost of living, inflation, IT costs are up, rent is up, everything is up. And we're not an EHE jurisdiction, so we're at the point now where we're cutting services and we're cutting staff positions, and that it feels very desperate if you are not in an EHE jurisdiction. So also hoping to hear, is EHE going to be expanded? If so, what year is that going to happen? Because we've been getting, again, kind of conflicting information and not really sure if that's going forward. And I know some of my colleagues have those same questions. Thanks.
So I'll start on some of that, hopefully most of it, but there, and then others can feel free to jump in. The administration has continued its support for the EHE initiative. It's our plan to come together this summer and look at the data and figure out sort of where we are, because initially 57 jurisdictions were based on, if I'm doing this right, 2017 data. We know some things have changed. We want to take a look at that. We also want to think about what a refreshed EHE might look like for 2025. So that doesn't completely answer your question about new jurisdictions, or are we expanding, or are we going to keep that whole phase thing? But it's something we want to come together and look and think about, especially as we have new data that will be released in June, and thinking about the plan for 2025. That being said, in addition to EHE and the administration's continuing support for it, there's also the continuing support for our other ongoing HIV work. The call by CDC to sort of stop one funding stream and was really designed to administratively align the funding opportunities. So they're trying to work toward administrative simplification of both your ability to sort of have to do, rather than having to do two different responses to funding announcements, you want to combine them into one. So that meant they had to send a letter out to sort of stop one, but we are continuing to support HIV prevention. I think grants management won't allow them to say those words exactly the way I said it, but just like all funding opportunity announcements, they are based on federal funding, on funding availability. That I can say, because that's a phrase we use a lot in HRSA. Based on funding availability, there will be HIV prevention in states, and there will be the EHE initiative. I think the other thing that you mentioned is paying providers when it comes to PrEP. As we talk about a national PrEP program, that is included along with praying for wraparound services. Another example of federal collaboration.
Go ahead, Joe.
Thank you. Joe Kerwin from New York State. In identifying key issues today, I just wanted to make sure we didn't forget about the aging population. Those over the age of 55 in New York State, that's more than half of our current population. I think they're facing unique challenges. Some of them are ones we faced 30 years ago around isolation and depression and all of that, but also I think in terms of provider capacity to deal with the challenges of aging and HIV, I think are presenting kind of unique and emerging situations that it feels like we're a little bit behind the curve on providing that kind of expertise. So just wanted to make sure we had that issue on the table today as well.
And Joe, I know we actually have a session on aging. I was quickly trying to look in the agenda as to when it's happening, but we do have a session during this meeting next couple of days around that. So yeah.
Hi, Annette Rocco from Massachusetts, and I promise I haven't forgotten my question this time. For those of you who were there last night or yesterday. A couple of things. I just want to piggyback on what Joe said, because the other thing I want to mention is the difficulty in helping our aging population navigate Medicare is a huge issue for us. So the other thing I just wanted to bring up is in terms of the workforce, and I'm sure all of us in the room have the same issues, but we're having a horrible time recruiting and retaining staff. We're very understaffed. And the strength of Ryan White has also become some ways our burden, because we did such a great job working with community organizations to provide services for HIV that now everybody wants to put everything into those contracts for the Mpox response and the COVID response. And a lot of it's falling on us in what used to be mainly, HIV services, because nobody else seems to have the relationships in the community and reaching the target populations that we have. So I just mentioned that because we need help with shoring up staffing to handle that influx of responsibility. But I also do want to mention specifically for HRSA, Laura, is because it's very hard to recruit staff now, a lot of our staff are union, and the unions have managed to negotiate significant increases, appropriately so. And the administration has come to the table and approved them appropriately so because they needed to. But what that means is that our administrative costs on HRSA are going to be impacted because of the 10% cap. And it's really an issue. I'm not sure what's going to happen actually now because of the both the salary increases and the fringe, tax and fringe. So I raise it as an area. I think workforce development is a huge issue now on so many different fronts. And I would urge you guys on the federal level to be cognizant of that, because the other piece that I'll mention, this is my bone that I chew. You know, we all know that public health got disparaged horribly during the last administration. And I really think we need to go out there and advertise the hard work that people have done. I mean, I know for us at our state laboratory institute, people were working 24/7 for months on data collection for COVID, so on and so forth. And I feel like there needs to be a public acknowledgement of that work so that the public understands that what we do to ensure their health is not something to laugh at or make fun of or be suspicious of. So I would just put a plug in for that too. So thanks.
Going back to the aging issue just briefly, so I completely agree that where we are in the pilot program around people being ready to take care of older people, we don't have all the systems in place that we need by any means. I think it did sort of sneak up on us a little bit. I think we were aware of it several years ago. Actually, Jules Levin, let's just call him into the room here. Certainly, he raised it very early. I mean, he was prescient about hepatitis C. He was prescient about aging. I got to give him that. So we were hearing about it and trying to figure out what to do. I think part of the challenge is that we don't have a really strong bench of people that deal with older people in this country generally. I mean, if you look at elder care in America in terms of both elder care services at large, but also in terms of like the expertise around medical care for older people. There aren't geriatricians on every block. They just don't exist that way. Most geriatricians do not see patients for primary care. They see them once and send them back to their regular doctor. So we work really closely, I think, with ACL about, you know, to try to figure out what services are actually funded in communities and what systems actually work, and trying to make sure that the Ryan White program isn't like starting from scratch and learning how to deliver elder services. Obviously, there's a difference in terms of some of the LGBTQ specific and population specific issues, but I think there is a body of knowledge that exists in communities and making that application. We've worked really hard on that. One second, and around the whole Medicare, we saw that coming too years and years ago. People would say, "I'm a smart person. I've been HIV advocacy for 20 years, and I can't figure out how to get to Medicare or what it was to do." So the ACTA Center has been specifically focused. That's our sort of hub around eligibility. Has been focusing on that for a while. There's obviously more to do, but it is a complicated entry in. The other thing in terms of some of the workforce things is we are looking at the AIDS education training centers and what they do and what they could be doing differently or more. There's so many competing priorities, frankly, because we've got all these people out of care, right? We know that's a big challenge. And how do we reach the out of care? What is our balance there versus people that are in care? And just with limited resources, how do we divide that up? So just a few of the things I'll say on that side. And the fact that we do have that 10% administrative cap, we did try to untangle a lot of people that can claim like they do clinical, but like super like paper where social workers were doing supervision of staff and that sort of thing that was in the clinical setting, clinical. So we tried to like unpack as much as we could with our lawyers to put it out of administrative. But I do understand that administrative cost cap is a challenge. Programming is your friend there. So just to be remembering that, I think there's a follow-up around aging on this maybe.
No, I just wanted to comment that, you know, it's interesting your point about Medicare and navigating that. That is an enormous issue. And, you know, we have difficulty on the state side making that bridge to Medicare from the Medicaid and the long-term care side, which presents its own challenge at times when individuals are turned away from long-term care facilities because they don't want them coming in with HIV meds. So they don't want to manage that. They don't want to cover those costs. That's kind of an extreme example, but those are, you know, the types of barriers that people face. It's always interesting to me too that at this meeting, CMS is never represented.
Noted. And I say that a little tongue in cheek because often CMS is not represented at any of the meetings that we go to. So actually, I'm sorry. Actually, we'll have you do one, and then I do want to check with folks on the line. So for folks on the line, you'll go next in terms of any questions you may have that we can read on your behalf, and then Barry as well.
Okay. So good morning, Kathleen Brady, Philadelphia Department of Public Health. So I have a comment and a question, and the comment is related to the HIV and aging, and that's really to tout some of the work that we're doing in Philadelphia. And so actually tomorrow, in collaboration with our AIDS Education and Training Center, we are holding a symposium on HIV and aging for people living with HIV. And so we're pretty excited about that. We've got folks from Philadelphia Cooperative Aging, folks from housing coming, legal folks from our AIDS Law Project coming to talk about, you know, planning for end of life, criminalization, et cetera. And so we're very excited about one of that we're doing that, but also with our EHE funds, we're actually going to be holding some focus groups and key informant interviews with people living with HIV to determine what the needs of that population are. And we've allocated funds within our HRSA EHE funds to be able to fund those services. So that's something that we're pretty excited about. So the question though is it's both on the HRSA and CDC side, and that is based on what we saw yesterday in terms of the proposed fiscal year 24 president's budget. There is actually flat funding for both HRSA, Ryan White, and CDC HIV prevention funding. And so although there's proposed increases for EHE on both the HRSA and CDC side as a EHE jurisdiction, that's great. But in terms of I'm going to talk specifically about HIV prevention. We're now in the 6th year of 18-1802 with flat funding over 6 years, which is essentially an enormous cut in funding over that time period. I've had to switch both surveillance and prevention staff to EHE funds in order to not lay off people. And so there's just no way that we're going to be able to end the HIV epidemic in the US if we are basically continuing to operate with flat funding from HRSA and CDC. So I guess it's more of a comment than a question, but I guess why is that?
So as we look at our data for and think about 2025, we need to look at it holistically. I think that when they first developed the EHG model, I'm not sure how they accounted for the work that HRSA and CDC do on the regular, I guess I have to stop there. But you know, as you get more people into care, into the Ryan White program, those expenses should be going up too. I'm not remembering last time I looked at the model, how that was all sort of taken into account and thought about in terms of the budget and the overall ask. But I'm hoping that as we sit down in the summer and look at some of this and think through it, we can have a better approach that helps inform both OMB and Congress to set the budget.
So on the way that was calculated on the Ryan White side was that the EHE funds, the new people that were brought in here would be sustained in the EHE funding. And all the increases that came every year in EHE were to get the new people to be bringing on board. But I think the question that Dr. Brady was asking was specifically about the base Ryan White funding is stable.
And what does that mean when your costs are increasing across the board?
Yeah, yeah. I mean, I would say this is something that we at NASTAD, Emily and her team spends a lot of time advocating for and educating on the Hill. So for those of you who are going on Hill visits today, please include those as part of your talking points, making sure that we have increased funding to the core funding for HIV prevention and care services. All right, quickly, I know we have about 10 minutes left, so let me just check in. Kyle, do we have any comments, questions from folks on the line? Not right now, perfect. Barry.
Hi, good morning. My name is Barry Callis. I work for the Office of HIV and AIDS in Massachusetts, and my work falls into 3 buckets: all things planning, community engagement, and the health of our populations. And I have 3 points that I wanted to make this morning. The first point is, having just, Elaine, thank you for mentioning the integrated plan. I think that that's all on our minds. One of the things that we did in Massachusetts is to make sure that that plan leads with racial equity. And to the point about EHE, in Suffolk County, we're glad that we have benefited from being part of the EHE initiative in Suffolk County. It's allowed us to have new vigor in our response. My recommendation to you all to consider is, I don't think that any of you or any of us don't want to end HIV. I wanted to recommend to you to see all of us as EHE jurisdictions in the future, because when some of us benefit, others don't. And when we can't all benefit from the same activities, we're not able to leverage the same kind of response. So I just wanted to put that out there to recommend that you consider all jurisdictions in EHE jurisdictions, because we don't make a distinction between what's in Suffolk County. We don't make a distinction between what's in Suffolk County and what's in the rest of part of the state. Our advisors told us, even though we have a separate EHE plan and group and set of activities, we don't make those distinctions locally. Our plan that we just submitted to you all is EHE for Massachusetts, inclusive of what's in Suffolk County. So I just wanted to put that out there. I would not be doing justice if I didn't carry the voice of people who helped us develop that plan to lead with equity. The second point that I wanted to make is, just as we are rapidly expanding how we go about serving our people differently, I wanted to recommend to you all that your current and future program announcements that fund training and technical assistance meet us with that same level of flexibility and responsiveness. And the third point that I wanted to make is about the many new doors that we're knocking on and that are opening for us. If we don't invest in community-based organizations and smaller entities that both represent and give us entree into new populations that we need to serve better, we're not going to succeed. Our COVID-19 vaccine work, our vaccine equity work, our monkeypox response, the success of that has all based on the doors that we knocked on and that were open. So I recommend that in future program announcements, there might be a carve out so that we can invest newly in some of these organizations, and maybe quite differently than we might in a community health center or a larger funded organization. Thanks so much.
Thanks, Brian. Thanks, Barry. Debbie.
Debbie Gilbo from Kansas. And so my title, it's really interesting because my title is like STI HIV Prevention, Care, and Surveillance Section Chief. So we've been braiding those services for years and integrating those services for years. And I heard yesterday at the low to moderate incidence breakout session that many of those jurisdictions that are considered low incidence are having that same. It's like, we don't have any choice. We're too small to do anything else. So I think there's a couple of things that I would ask you guys to think about. And I echo everything that has been said here. But in particular, the 10% cap on HRSA funds for Ryan White. If we are truly looking at braiding systems together and braiding funding together, perhaps there's a way that another funding source can come along and help support that 10% cap so that, because we're right, it's true that as we receive level funding, we're actually receiving less. And I know in Kansas, our prevalence has gone from like, I mean, we just continue to raise as far as the number of people that are living with HIV in the state. Our new incidence rate stays about the same, but our number of people living with HIV is just like skyrocketing. And so we don't have, you know, as we get new people, as we add, we're not having the funding to support that. So just a thought, an idea, maybe something out of the box is if you could think about some way that some of these other funds could weave in to support that administrative cap on HRSA, that would be really helpful. And I know we have rebates, but typically in our state, that turns around and goes right back into more meds. So there we have it. So.
Looking around the room, any additional questions, comments, feedback? Randy.
Randy Mayer, Chief of the Bureau of HIV, STI, and Hepatitis at the Iowa Department of Public Health. Harold, I want to come back to you. I mean, you started talking a little bit about molecular surveillance and a little bit about cluster detection and response, and you've had a lot of meetings and conversation with community, touched on criminalization. So I just want to give you the opportunity to say a little bit more about kind of what your thoughts are and where you expect us to go with the next FOA.
So CDC is currently developing the next FOA. So I'll start with molecular surveillance still remains an important pillar in our EHE work. It is a pillar that is really important because it touches upon all the others, from diagnosis to treatment and linkage to care and prevention. It also is a pillar that allows us to work collaboratively across agencies that include HUD and SAMHSA as part of the response and HRSA as part of the response when we identify clusters. I think there are ways, and we are continuing to explore ways to continue to protect the use of that data and surveillance data in particular and preserve it for public health uses. I think that we have heard a lot from the community and from others about the concerns about the use of this data for criminal prosecution. We don't yet have an instance where molecular surveillance data has been used for criminal prosecution. But given the community concern, we are continuing to sort of explore how do we put additional protections around that data and still use this tool in the right way to be responsive and find those who are out of care, not in care, and sometimes not even aware of our systems. I think there's a way to do it. Some of the outcry and the concerns for me are also very similar to what we had when we initiated names reporting, and we found ways to do that without the sky falling in. I think we can do the same thing with this. We will continue to have some meetings and some discussions about how it gets used and how we also protect it and protect individuals' privacy.
Robin, anything to add?
Just thank you, Harold. I think the only thing that I would want to add is, we are in agreement. There's also been a considerable amount of community engagement from leaders, Dr. Alexa Holster, who's our chief of the detection and response branch, doing this work very directly with the community. I think for us, we're thinking about activities that we can do to support what we've heard, and those include, as Harold said, strengthening data protections, supporting states in modernizing HIV criminalization laws, providing peer-reviewed evidence for CDR. So there's a recent science brief that you can look up that I really would recommend. It has almost 100 references really supporting science behind this work. But besides the science, I think in what I have presented about women, Black women, transgender experience in Detroit, how sometimes this work is really saving and achieving lives. And I think something that we've also heard is considering the possibilities for an adaptive framework when it comes to CDR activities by jurisdiction. So there's more work to be done, as Carol said, they're engaging in further conversation, but those are some of the activities that I know that we are either doing or doing.
Thank you, thank you, thank you. It is really one round of applause. We've been applauding each other, but let's give a round of applause for our colleagues. Hopefully we've been nice enough. You're going to come back in future meetings, but thank you. Thanks to all of you for the engagement and the questions, the thoughtful questions, the important questions that for you to be able to do your work most effectively. We're exactly right at time, and so I'm going to end here, but I know we have Hill visits and lunch boxes coming up. Emily and or Mike, any final comments or guidance for folks on Hill visits?
Just a couple of quick reminders. You can grab your box lunch now and meet up with your NASTAD staff member. NASTAD staff, please use your NASTAD card or your personal card with the code 2000G for Ubers or Lyfts to the Hill.
All right, thanks everyone. Make sure you wear comfortable shoes.